So let's talk about the management of this terminal illness basically. There are no treatments, there is no cure yet, but there are goals of care that we should work through with patients and their families to improve their quality of life. The first one is care planning, second one is symptomatic treatment, the third one would be slowing the disease progression. So care planning involves occupational therapy, home care, placement if needed, like in an assisted living or a nursing home, planning advanced directives, and caregiver support, which is a new and a very important aspect of dementia care, including psychoeducation on the nature of the illness, nature of symptoms, how to deal with them, offering them their own therapy, support groups, helping them with financial planning, hooking them up with elder lawyers to handle the property, the finances, and how to allocate resources. Case management is almost often needed, and some may need treatment themselves. Some caregivers end up having a diagnosable mental illness due to stress, even if it's just adjustment, and they need treatment themselves. Next is the symptomatic treatment of behavioral symptoms of Alzheimer's disease. And we could use different modalities like behavioral management using the ABC model, which is short for antecedent, behavior, and consequences. Therapy modes like reminiscence therapy, validation therapy, supportive therapy, and sensory integration therapy directed towards the subjects suffering from Alzheimer's disease. There are pharmaceutical agents that can help us mitigate some of the behaviors. For depression and anxiety, we could use antidepressants. For compulsive behaviors, we could use SSRIs. Sleep is a big component that needs a lot of attention and can benefit from a lot of pharmaceutical and behavioral interventions. Psychosis and aggression may benefit from SSRIs and antipsychotics. Mania may benefit from antipsychotics and mood stabilizers. Last but not least is exploring options that can slow the progression of the disease, including health optimization, non-pharmacological treatments, and pharmacological treatments. So health optimization, meaning optimizing the other aspects of the patient's health other than his cognition, including his vision, his hearing, to optimize the input from the external environment, examining their medication, their general medical health, examining their mobility, making sure that they can walk safely. And smoking cessation is also important because it has been found that particularly those with the ApoE4, smoking can be quite detrimental to the progression of Alzheimer's disease. Non-pharmacological may include diet adjustments, sleep hygiene, exercise, increasing social activity, and some benefit from cognitive rehabilitation using cognitive exercises. Last are the pharmacological interventions, including cognitive enhancers and monoclonal anti-amyloid agents. So let's talk a little bit about the monoclonal anti-amyloid therapies. So these are the most recent disease-modifying agents on the market, have been in development for the past 17 or 18 years, and these are basically lab-created antibodies that flag the toxic beta amyloid in the plaques for removal by the immune system of the brain. The first one that was FDA approved was the aducanumab, which is also called Aduhelm, in June of 2021, and there are several other more in the pipelines. These compounds are currently indicated for mild cognitive impairment or early dementia due to Alzheimer's disease, which means that the subject should show screening scales showing measurable cognitive deficits in at least one domain, plus biomarkers of Alzheimer's disease, which I will discuss on the next slide. The three known compounds so far are the aducanumab Aduhelm, but it was discontinued by Biogen in January 2024 for financial reasons. The lecanemab, which is also called Leqembi, is the one currently most popular in the field. The third one, which is still pending FDA approval, probably later in 2024, is called donanemab. So there are several side effects, but the most remarkable ones that we are always monitoring and should be aware of are infusion-related reactions happening at around 20% of cases with Leqembi, the amyloid-related imaging abnormalities that classified in two types, ARIA-E, which relates to amyloid-related imaging abnormalities in the form of cerebral edema, and ARIA-H, which are amyloid-related imaging abnormalities in the form of microhemorrhages. The cerebral edema is more likely to happen with higher doses, rapid titration, and those with ApoE4 alleles, whereas the hemorrhage happens more in those who have a history of cardiovascular accidents and advanced age. There are also trials ongoing using the same compounds but for other stages of Alzheimer's disease, including preclinical Alzheimer's disease, who have positive amyloid in their scan. They're showing the biomarkers, but they don't have any symptoms at all. And they do not have measurable deficits in their cognition. And this is as of March of 2024. So what are the biomarkers for Alzheimer's disease? So what are the biomarkers for Alzheimer's disease? We have two groups. One is considered suggestive of Alzheimer's disease, pointing to the need for further investigation. These include the ApoE4 allele. If you have one or two copies, makes you more likely to have Alzheimer's disease if you're suffering from any cognitive deficits that are measurable and interfering with your functioning. The second one is using brain imaging like a CAT scan or MRI with volumetric measures and examining if there is some regional atrophy, especially if it's affecting your parietal and your temporal lobe. Third is using a PET or a SPECT scan to look at the local reduction in metabolism, especially it's affecting your parietal or temporal lobes. These would point you to pursue further testing and see if the subject may benefit from these anti-amyloid monoclonal therapies. These include the amyloid PET scan, which basically examines the load of amyloid in the brain, and these are now covered by Medicare as of January 2024, which wasn't the case last year. Lumbar punctures and examining the ratio between the p-tau and the A-beta 42 protein, and if this ratio is higher, means that the load of the amyloid in the brain is higher than what the ApoE protein can remove. And it's covered by some of the insurance plans, but not all of them. And there are newer blood-based biomarkers for Alzheimer's disease that are not commercially available yet, including the plasma p-tau 181, 217, and 231. So that brings me to the last slide of this section, in which I'd like to shed some light on the trajectories of Alzheimer's disease with anti-amyloid therapies. And bear in mind that the data that we have so far is quite limited because these compounds are fairly new. The preliminary data that we have so far shows that with MCI, we basically buy them around 8 months or more before they start slipping into early Alzheimer's disease. When it comes to early Alzheimer's disease subjects, they either get benefit for around 6 months, some of them will get the benefit for about 2 years, and surprisingly, there is a small subset of those subjects who actually stay at a plateau for much longer than 2 years before they start deteriorating into moderate Alzheimer's disease. And there are so many studies going on to try to examine why subjects respond differently to these same compounds. Thank you so much for paying attention so far through this lengthy and dense module, and I hope I see some of you in the next section where I discuss in detail more of the other types of major neurocognitive disorders affecting older adults.